Welcome to our world. So these patients mostly have multi-drug resistant TB. Notice the ultraviolet lights. That's to kill the bacterium that causes tuberculosis. They're watching Silence of the Lambs. And I just got them Lord of the Rings. Moi, sont belles vidéos. Toi, action. Oui. Já sentiu. Bonsoir, chérie. You know what she just said to me? I said, how do you feel? She said, I feel, compared to how I was, I feel great. I mean, she still looks like a skeleton to you, but she looks like a skeleton with 5 pounds extra to me. She started the 2nd of October on her treatment.
Wow. How much has happened over all these years? You know, this young woman was at death's door, and she's getting better. It wasn't a magic recipe. It was treatment that's been available for decades and decades. That's all it was.
So Cynthia wants us to see a patient.
And yet there were so many more people who should have access to basic medical health care. But it didn't have to be this way. There was a moment in time when it all could have been different. Colonialism had ended, and emerging nations planned bright futures. And in an almost forgotten historic event, in a place called Alma Ata, the governments of the world came together to make a revolutionary promise. Full healthcare would be extended to all, beginning with the poorest on Earth.
Health, which is a state of complete physical, mental, and social well-being, is a fundamental human right, whose realization requires the action by all governments.
Health for all is the future.
But this grand vision never came to be. Instead, larger forces from wealthier countries created plans that crippled the once rising nations. They ushered in poverty, disease, and chaos. And that is when we first met in Haiti. I arrived there late at night in January of 1983. I was 18 and a half. There was a part of me that felt overwhelmed by it because I was wrenched into the reality that I quickly realized was much of the world. I was volunteering for a group, an ophthalmic group called Eye Care. They had outreach clinics. That's when I met Paul. Paul and I clicked immediately and ended up talking about our lives and our families. I remember that I could see in him this restlessness with the world.
I'm just gonna clap in front of your face. Sorry.
We have medications for that, so. I remember this like it was yesterday. I was 23 years old. I hadn't even started medical school. I already had this deep interest in Haiti and Haitian culture. It was my first time outside of North America or Europe, and a place I really wanted to go. It was just fascinating. Certainly, I was, very young and enthusiastic, but I didn't know anything. That's where I met Ophelia. And she was even younger than I. She's still even younger than I.
And he was trying to get a job, actually at the Schweitzer Hospital, which he didn't get. Paul was helping to assist at this clinic in the middle of Mirebalais.
I wasn't acting as a physician, by the way. I was just taking vital signs, which I'd been trained to do, and providing some kind of moral support. There would be this enormous line out front of the clinic. So the doctor was about to go out of his mind. He's got no lab. He's got nothing. I mean, he would listen to the complaint, use the stethoscope like a magic wand, or refer or somewhere else. And I started thinking, we should be referring everyone somewhere else. And this was typical all over Haiti. And I was basically learning how not to deliver medical care. I was settled on being a doctor from the time I was probably 12 or 13. My father was a school teacher, and one year he got a job in Florida. So he ended up buying a bus, which was actually a bus used for screening tuberculosis. And as one does with a bus, we went to a campground, which was supposed to be temporary. And then it wasn't temporary. I mean, when I left for college, I was still in the bus.
His whole family connected to this very important sense of being aware of other people who were less fortunate. So when Paul arrived in Haiti, he listened very, very carefully and was eager to learn from those people who were living there.
You got to use the word serendipity, right? When I met Father Fritz Père Lafontaine, he said, yeah, you can work with us.
Paul, un jeune petit garçon, venu joindre moi que mi balai, il était parlé créole, il était parlé français. Alors, la communication était facile, mais il n'y a pas de bateau central du tout.
Father Lafontaine had been working with people even further out in a rural area called Cange. And this was a group of people displaced by a big hydroelectric dam project. When the valley was flooded, everything they had was gone, and they were forced up into the hillsides where they had nothing.
When I got there, I got to see what poor planning of a development project meant to poor people.
I had never seen such abject misery in my life.
What I saw was traumatic. It certainly taught me to respect the destructive power of poverty. And I thought, how can we get this fixed?
So we wanted to do some kind of an assessment of what the needs were.
I remember Father Fritz said, well, you can ask them, they're just going to tell you they want a hospital. Well, he was right. Oh, and proper housing, too. And you know what? We want our kids to be in school. We knew right then and there that we had to get a plan and build a clinic, but we had no money.
Paul était tendance que tu déposé pièces li à droite de l'université.
Fritz handed me my acceptance letter into Harvard Medical School and punched me in the stomach, like, here. He was very excited. He assumed that it was an acceptance. I didn't know.
Au cours de où qu'il voulait rester, travailler ici, et moi-même, moi parti d'accord.
He lectured me sternly about it. And he was right, you know. It'd be a lot more effective having those credentials. When I left for medical school, I dreamed of building a clinic and then a hospital. Again, we didn't have any resources. I certainly didn't have the experience or maturity or wisdom, but that doesn't mean it wasn't a good idea. I met Jim Kim on a snowy night in December 1983.
Paul was dressed almost like a dandy. He had very fancy clothes and a nice little scarf, and I was only later to learn that he'd borrowed every bit of it from someone else. We began talking, and I thought, wow, this guy is really impressive because he could participate in the seminar, as if he was one of the professors.
Jim and I clicked. We were in the same training program. That's when we really became very close friends.
Paul and I both agreed that we were going to medical school for reasons of social justice. Now, let me just stop for a second. This is really important.
Shall we?
During medical school, we spent many, many late nights, Paul and I, and Ophelia, talking about fundamental questions. What is the nature of our responsibility in the world? Is there something like an area of moral clarity?
There are all these ideas, for example, appropriate technology. I mean, basically, in the end, they're all used to punish poor people, just like every other ideology is, by and large. So the appropriate technology means, as Fritz, our boss, says, that means shit for poor people and good things for rich people.
It was during those late-night conversations that I started realizing that these larger forces had an enormous and terrible impact on the people that we had gotten to know in Kanj. Almost immediately after Alma Ata, the world economy had crashed. Many countries suddenly owed huge debts they couldn't pay. Enormous institutions like the World Bank, led by the US, gave new loans to poor countries to pay their old loans. But there were strict conditions.
Unless a nation puts its own financial and economic house in order, no amount of aid will produce progress.
At that time, World Bank loans actually required the poor countries to cut investments in education and healthcare in order to make sure that the loans were paid back.
I learned about it in Haiti. Haitians were talking all the time about the American plan. It was ripping the safety net out from under people as they were already falling.
We realized that poor countries weren't poor because of some kind of moral failing, and we felt that we needed to use our own opportunities to do something about it.
At that time, Ophelia Dahl and Jim Kim, plus my college chum, Todd McCormick, that's the group that got together.
Jim and Paul were debating issues long into the night in ways that I would, be kind of, cooking the chicken and making the hamburgers and listening like, this is, way above me. And we knew we needed to get other bigger funders involved to build a clinic in Kanj.
And we were introduced to Tom White, actually through a group here in Boston.
Tom White, you are kindred spirits. Yeah.
Tom and Loie, his wife, wanted to give all of their money away while they were still alive. They didn't want to die with money in their bank. And then Tom White gave us the first tranche of money to build a clinic, and Partners in Health was formed.
We didn't know what we were doing. We didn't know how to build a clinic. We were pretty excited. The Partners in Health team was growing.
I met Paul, and we spent like hours discussing, social justice with Haiti, and that's how it started. That was my job interview.
As soon as we opened the clinic doors, everyone who was sick came, and it was every possible disease you could imagine.
C'est Corée de la Salmon Chantier? FF. Okay.
People start coming from Mirebalais, from Thomone, from all over the place.
Majorité moun qui te kon ap vini marcher 5 heures de temps, 6 heures de temps pour yo joindre l'hôpital. Mais c'est des moun qui des fois qui te malade en pile.
Bonjour, messieurs, dames. Bienvenue. Bonjour. Merci pour patience, nous.
Certainly, I didn't know how to build a proper hospital, right? I mean, to be honest about it.
Okay. Bonjour. Bonjour.
Early on, when Paul was at medical school, he would go to his medical school classes as much as he possibly could. He would often leave on a Thursday afternoon, get down to Haiti. He would start already trying to translate what he was learning, and then he'd come back on a Sunday, and then he would start all over again.
Jim and Paul were constantly going back and forth. In fact, it was a dizzying degree. And they would, let's say, borrow things from some of the hospitals to improve the situation in Haiti.
Actually, the first sink we had at the lab was bought by Paul from Boston, on the plane, carry on.
You know, we constantly had troubles funding the organization. Every week, it seemed like there was a new crisis in terms of funding.
See, money, that's the problem. We don't have the money. But that doesn't mean we can't get the money. We can get the money.
Is that being donated from some?
Well, I have to say right now that this medicine was billed to the hospital I work for in Boston, and they never charged us. Let me just say that again to be more politic. Yes, this is being donated by the Brigham and Women's Hospital in Boston.
We never thought that there was any heroism in that. We wished that there was funding for us to just get the right equipment and medicines.
When Jim arrived in Caen, he was a very keen observer of everything that was going on there.
My biggest role in Haiti was really helping Paul do his work. I really see that as my apprenticeship, not only working with him, but also in understanding how you take a notion of social justice and turn it into real work on the ground. I was born in Korea in 1959, and back then, it was a really, really poor country. So in 1964, we moved to Muscatine, Iowa, 25,000 people. My father was a dentist, my mother was a theologian, philosopher. And one day, my father said, so Jim, what are you thinking of studying? And I said, well, I think I'm going to study philosophy and political science. And he looked back at me and said, look, you're a Chinaman. You think people are going to pay you to listen to your opinions about politics? You need a skill. I think my father taught me something really important, that if you come into a situation with something that actually can help another person, it's a good entree to begin a different kind of conversation.
Bonjour, Margaret. Margaret. Di po ko ali? No. Ano menen? Onali.
In those first years in Conge, you didn't have to wait long until you met someone with tuberculosis.
Examen pulmonaire de Chiawe. She's in a bad way. She actually had been sick for some years, and I don't think it's safe to wait another 2 weeks. She could die in between now and then.
What happens with this disease if it's unchecked? It destroys the lungs. It destroys other parts of the body, too. So the patients can't breathe, and they're suffocating, and they're gasping for air.
Est-ce que vous sentez au fièvre sur vous?
In 1988, we had 3 people, all under 50, from the village where we built the clinic, die of tuberculosis. One of them happened to be a friend of mine. And she left orphans. This provoked a crisis. Nobody's supposed to die of tuberculosis if you have proper care.
Paul was just devastated. because he kept failing, meaning people would die of things they shouldn't have died from.
You know, we'd seen all these vivid things and knew that we didn't really understand them well enough to be, you know, effective. I certainly learned that the hard way. So we said, okay, we're going to bring everybody together and we better figure out what went wrong.
Alors, il y a 3 personnes qui étaient mortes avec tuberculose ici. Et pour ça, ils ont mouru. Ce qui n'est pas bon avec le système noir, parce que nous avons des médicaments gratis, laboratoire gratis, tout va gratis, et ils ont mouru.
The people trained like me, the professionals, blame the patients for their bad outcomes. She's superstitious. She didn't take her medicines. And on the other end of the spectrum were explanations like patient's too poor, doesn't have enough food to eat, too far to get to the clinic. And those moved the responsibility out of the patient and into the circumstances.
Ici, yo vive famille, c'est comme ça.
And we said, okay, let's make sure that you're not alone with this fighting diseases. Listen to the person. Sometimes they go days without water. If you're too sick, we cannot walk hours to get water, to take your meds.
It was an indictment of the system that we built. And that's why we developed the accompaniment system. That's what the Haitians called them, accompagnateurs.
Oui, an accompagnateur is someone who's there for you. Someone in your neighborhood to check with you every day.
Vini 2 fois par jour. Non seulement je le médicament, mais m'encourage pour le prendre parce que s'il ne pas prendre, il est toujours malade. Il quand même mourir. Ça nous fait un petit parler, un mot d'encouragement, capable d'encourager. Vous connaissez les malades, c'est pas tout le monde pour encourager, capable de décourager facile.
So when we took the blame off the patients and put it on the system, everybody got better.
This accompaniment system, which was the core of the TB control system in Conge, was wildly successful, and we reached almost 100% cure rates.
If you think about it, it's a remarkably simple model.
Really?
And it became essential to the work.
Is it okay to write Bravo in a medical chart? I mean, you gotta love this job.
After we got the experience with community health workers in Conge, we decided that this could be bigger than just the project in Haiti. We decided that this could be something like a movement.
I went there and I said, huh, yeah, this is where I should be because I don't have to worry about being able to give care to people because the lack of means. We feel such a relief when you could make a big difference in people's lives.
When I was a young child, I saw a lot of suffering in Calcutta, where my dad was from. So I was always very interested in health problems of poor people from a very young age. And someone said, you should talk to this guy, Paul Farmer. And I said, well, you know, does he have a sense of humor? And they said, yeah. I said, because if he doesn't, I can't. Like, I just, it is too dark to just go into this with like a missionary, like here, sorry, nothing against missionaries. But they said, no, you should talk to him. So I told him I'll work for free, and he said, well, you have a job then.
Our team was growing in Haiti, but someone who would change the course of our work entirely was Father Jack.
This time, I'd like to just invite people to stand as we mention the countries in which you come. So as we call
Father Jack was a much-loved priest in a hard-scrabble Boston neighborhood called Roxbury. His flock consisted of church ladies, gang members, and Paul, who moved into Jack's rectory to save rent during medical school. He was bawdy and irreverent and funny. He was not your average priestly priest. We loved him. Jack's long-held dream was to serve the poor of South America. And one day he decided it was time, and he left for Peru. And he encouraged us to grow our work beyond Haiti and come to the outskirts of Lima and see what we could do there.
At that time, the World Health Organization, or WHO, which is the United Nations agency that monitors diseases and establishes protocols for their treatment, considered Peru to have one of the best tuberculosis programs in the developing world. So when Father Jack invited us, I decided I'm going to start a project and I'm going to figure out how to make an impact. One of the first people I met was Jaime, and we hit it off right away.
Era médico de una parroquia y en ese distrito y el padre Juan trataba de ayudar de la mejor manera posible, pero ciertamente no se daba abasto. Lo que me impresionó del Dr. Kim fue su auténtico compromiso por ayudar.
We began working with a group of young people who we were training to be community health workers.
Those young people who would visit homes and see what was troubling people.
We saw so many things that were disturbing. We saw people not able to feed themselves. We saw healthcare services being cut back. And we attributed a lot of those things to the World Bank.
Creditors are now insisting that Peru gets its economic house back in order. The austerity program being forced on the country will mean more cuts in government spending. In other words, hard times ahead for everyone.
I traveled with Paul, with the team, to Peru to see what the challenge are. We stayed there and we built the accompaniment model.
By then, I was specializing in infectious disease, and I just knew a lot about tuberculosis because of Haiti. My report from that trip, which I'm hoping is lost, I said, maybe here we should focus on primary care, women's health. And I said, but happily, Peru has a great tuberculosis program, which is another colossal error.
And then we started finding these tuberculosis patients. It's total whiteout on the right side. There were patients who were getting treated over and over and over again in this program, and they were not getting cured.
There were a lot of people who were coughing, who had been to the clinic, who had been put on treatment for tuberculosis. They were taking each and every drug that was prescribed to them, and they were still sick. And that was surprising.
We said, well, they must have drug resistance. But then what we heard was no drug resistance in Peru. Our program is so good, no drug resistance.
Tuberculosis is an airborne disease, so the stakes have always been higher from a public health perspective because you can't control the air. It's very important that you take medications and stay on them for the duration of the treatment.
We started seeing patients who had been treated with first-line therapy, not once, not twice, and they still had active tuberculosis, meaning they were transmitting it. So there was a big hole in the program.
As we were just sort of figuring out that this problem was going on, Father Jack got sick.
I thought to myself, wow, he looks older or skinnier or something.
When we saw how sick Jack was getting, we begged him, we pleaded with him to come back to the United States for treatment, but he refused. He said he'd made a very strong commitment to his people, and that's where he belonged.
And then Father Jack got very sick. And we knew that he had to get back to Boston for medical help immediately. Jim and Paul spent a huge amount of their time in the hospital, with him, in the room.
He got really sick very quickly.
He died.
You know, looking back, you know, over the last 30 years, even though sometimes we like to say we're quick out of the box, we're still way too slow. Because there's always this period where you say, please tell me this is not my responsibility. And that delay is lethal. And that's what happened to Jack. He got sick in the delay.
And then we found out that he had drug-resistant tuberculosis. This had a huge impact, particularly on Paul and Jim.
With Father Jack's death being diagnosed as drug-resistant TB, we began to suspect that there were many, many cases in the community.
And we thought, my gosh, how many of these kinds of patients do we have?
Tuve la oportunidad de entrevistarme con enfermeras de los diferentes establecimientos de salud. Pero el personal de salud no se sentía con la confianza necesaria para compartir información de los pacientes. Pero en un establecimiento de salud tuve la oportunidad de tener una conversación donde la enfermera me mostraba los datos y me dice, alguien tiene que hacer algo.
Mira la resistencia que tienen a estos medicamentos y no se sanan.
Y como esos varios.
Sí, como estos hay varios.
Just looking at the number of patients who are not getting better, we thought that we might have as many as 50 cases in a town of 100,000. So to have 50 drug-resistant cases per 100,000 essentially is an outbreak.
What we saw were clusters of drug-resistant tuberculosis where one person would then transmit the drug-resistant strain to others. Those others would still seek care from the TB program, and those drugs would not cure what they had, and they would further spread drug-resistant tuberculosis. So without the proper treatment, those strains started to dominate in families.
The medicines for MDR-TB were really expensive, anywhere from $20,000 to as high as $35,000. And they were very rare. And so the World Health Organization actually had an official policy on MDR-TB. They said it was too expensive and that they didn't think that MDR-TB should be treated in poor countries. What the WHO says about treatment protocols is taken as religion in most of the developing world because they don't have the expertise to develop their own treatment protocols.
En relación a países como Perú, debido a la complejidad del manejo de estos pacientes, mejor no preocuparse por estos casos.
So anyone with drug-resistant tuberculosis, the assumption was they would just die.
We went to the local authorities and said, look, there's a lot of patients with drug-resistant TB. We should start treating them. We're going to have a huge problem on our hands unless we get going right now. And the head of the TB program said, if you treat a single patient, we will kick you out of the country. They were livid because they thought that pointing out that the program doesn't work for drug-resistant TB would threaten all the gains that they had made.
Nos pareció que era una tarea no solamente difícil, sino que iba a ser un fracaso.
It turned out that one of the Peruvian TB doctors had a daughter who was in fact sick with multi-drug-resistant tuberculosis. But he quietly came to Paul one day and said, can you please treat my daughter? So we in fact did treat his daughter, and his daughter got better. And they let us treat a small group of patients. We had a conversation with the young community health workers, and we said, we're going to start treating these patients. You're going to have some exposure to MDR-TB. This is a deadly disease. And it's amazing because all 12 of the original health workers said, yes, we're going to treat these patients.
It was a nightmare, a logistic nightmare, financial nightmare.
Everything was conspiring against us. It was so difficult just to find the medicines. We were calling public health services in every state in the United States to see if we could find these vials, and we would literally buy them from them.
We needed hundreds of thousands of dollars to treat a small number of patients rather than treating 1 million patients with other problems in Haiti. That was very hard for us to deal with. Were we doing the right thing?
And Tom was paying for all of it. I mean, it was really Tom White. He didn't want to be the only one funding treatment for drug-resistant TB in the world, but this was life or death. Getting those medicines down there, not interrupting anyone's treatment, was life or death. There was no special help in bringing the medicines in. I would put that medicine in these big suitcases, and because I was Asian, they usually thought I was a tourist, and they let me through a little easier.
We knew that these people were in for a very rocky treatment course if they were going to survive their disease.
Both Melquiades and Julia were what the Peruvians called crónicos, patients who'd been receiving treatment over many years and were not getting better. I have to tell you, when I saw Melquiades, I thought, oh my goodness. I would not be surprised if he died. We've left him without MDR-TB treatment for too long.
Sabemos que es muy difícil tomar todos los medicamentos, pero no, ahora no tenemos otros. Es difícil ahora, pero por favor, continuar.
The stakes were so high, and we pushed very, very hard. We knew that we had to have success with these patients, or treating MDR in the rest of the world be written off forever.
Esos pacientes ingresan a este esquema para tratamiento de multidrogresistencia con la esperanza de ser curados, pero no con la seguridad de que eso iba a ocurrir.
Community health workers would go to the homes 6 days a week for as much as 2 years at a time.
El tratamiento consistía de más de 11 medicamentos que se tomaban los pacientes al día. A ver, Melquiades.
No tengo ganas de tomar más, porque no me siento bien conmigo mismo.
Estas medicinas tienen efectos secundarios fuertes, pero son los únicos medicamentos que pueden ayudarte a eliminar el bacilo resistente.
Tengo 3 años con medicina y nada. Nada, 3 años. Es peor aún.
Our patients went through hell in getting treated.
Melquiades, más que el tema de tomar los medicamentos, sí, es un problema de desesperanza, ¿no? De agotamiento. Y es entendible, ¿no? ¿Qué pasa?
These community health workers were very, very courageous and special people to be supremely compassionate with these patients who very well can infect them. Both the community health workers and patients, they didn't just do this for Caraballo. They did this for the whole world.
Sin guerra, no lo puedes ganar. Tiene que ser un buen guerrero. Yo voy a ganar. Así debe ser.
If the first patients got cured, then we knew that we had an argument. Because the first stage in the argument was, even if you wanted to do it, you shouldn't start because it's simply impossible in resource-poor settings.
We have a clip to play for you.
Fue una lucha en la que fue bien dura.
Wow.
Gracias al apoyo tanto de los doctores, tanto de
That's
familia,
Melquiades.
tanto de personas que realmente estuvieron ahí, se puede decir que estoy aquí.
We almost let him die. think we almost let him die just because we thought it was inconvenient for us, just because we didn't think that he deserved it. I've seen others like this, but it's just, this is, what a transformation, my God. I mean, look at this confident young man, you know, who's out to take on the world.
Se puede decir que es caro, ¿no? Que involucra mucho tiempo, cuesta, todo eso, ¿no? Pero yo creo que lo vale, ya que más adelante se va a ver reflejado realmente en todas estas personas.
The first cohort was 75 patients. They were treated for 2 years with 5 to 7 drugs. 85% of them were cured, which was a very high rate.
And so we thought that we had to do something to change the way people thought about this first question, which was, is it possible to treat MDR-TB patients in resource-poor settings? We knew that these numbers were better than anyone was getting in the United States. So it took us from being outsiders in the global health world right into the middle of the debate.
So we brought together the big shots in TB and got them into this one room. It was Howard Hyatt's idea to do it with the express notion of taking on the policy.
Once the WHO announced that they would come, all of the good and the great in TB control came.
At that time, we were a very small NGO with a small clinic in Conj, 75 patients in Peru. You know, Jim, who was still moonlighting at the Brigham to pay a salary. I mean, it was just like we were little bitty. We were small potatoes.
And then we presented the results. And the results really, I think, were shocking to people.
I looked at your data and was quite struck by the suggestion that there was over 50% cure rate, that I just have a hard time accepting that those numbers will float unchallenged. It's impossible.
The vast majority of the TB community literally lost their minds.
Look at the results we just heard. 70% of the cases are cured. My belief is that those 70% never had multiple drug-resistant TB. They were folks that took some of the pills that were in the blister pack, some were palmed, some were sold. If you've ever been in any of these countries, you realize that their ability to screw up a program stems all the way from the top, all the way down to the bottom.
The old school TB crowd was furious.
How important is it to treat multiple drug-resistant TB? I don't think it's very important at all, because I don't think it has very much of an impact.
You know, even if we believe it, you can't do it.
Maybe it's a good idea, but where and when and for how long? We need to think about sustainability.
I've never seen this debate play itself out among patients saying, you know, I don't really think I'm sustainable.
The only time that I hear talk among people like us, academics, of shrinking resources, is when we talk about things that have to do with poor people.
The main resistance always is cost. These patients, Black people, brown people, poor people, just don't matter.
We feel that what could come out of this meeting is that the data that we showed you of our success in treating MDR-TB could lead to a vision of expanding resources that could be very powerful.
That meeting was, can it be done in developing countries? Boom, done. We proved it can be done in developing countries. And we actually showed how this was done using community health workers. Second step was, can you bring the drug prices down? Because they kept saying, how can you say that we should treat MDR-TB when the drugs are so expensive? I asked some people from the World Health Organization, so do you know if the drugs are on patent or not? And then they said, well, we don't know. And I couldn't believe it. I said, how can you declare a death sentence on everybody in the poor world with MDR-TB and not even know whether the drugs are patented or not? Because if they're not patented, we could drop the prices almost immediately. I asked one of our team members, just find out if these things are on patent. And he came back and he said, you know, all of them are off, and they've been off for a long time. And we were just shocked. No one had asked that question before.
Jim made it his priority to reduce the prices of these drugs. And the whole thing shifted. Drug prices dropped by 90%. All of that work led to massive shifts in protocols. It was a cascade of events that changed the policy at the WHO.
I remember Jim said, if we make this argument correctly around treatment of drug-resistant TB, HIV is next.
The lifestyle of some male homosexuals has triggered an epidemic of a rare form of cancer.
The world was being ravaged by a new plague, one that would show in stark relief what was acceptable and what was not for the poorest of the world.
It's known as gay plague. No, it is. I mean, it's a pretty serious thing that 1 in every 3 people that get this have died, and I wonder if the president is aware of it.
Over 300,000 people died in the US before the powers that be were forced into action. In poor countries, it was even worse. Over 22 million people worldwide were infected. In 1996, a combination of drugs was developed that would keep the disease at bay. It was called antiretroviral therapy. It was effective, but incredibly costly. Even the most powerful institutions in the world felt outmatched by the magnitude of the need.
When you come to look at the question of AIDS throughout Africa, you really get a sense of how limited is the capacity for contribution.
But some people were fighting back.
History will recall Reagan and Bush did nothing at all.
We became allies.
At that time, we decided to take as many activists as we could to the Amsterdam International AIDS Conference.
Shame on profiteers! Shame on profiteers! Shame on profiteers!
And we were meeting all these people from the developing world with AIDS that were showing up with pneumonia, with thrush, with huge herpes outbreaks on their faces, and no access to medicines. So we were literally digging through our medicine bags, giving people, our Sporanox to combat the huge outbreaks that were covering half of their faces of herpes. And going to Jonathan Mann and saying, Jonathan, there are all these people here. Some of them fucking have pneumonia. You've got to get these people, to a hospital and to a doctor to treat them. And they responded. But that outrage that other people with AIDS were showing up at an international conference, they were so fucking desperate, they were getting on planes with pneumonia, to make their story be heard, just hooked me.
Governments are killing poor people in developing countries because they are providing only a tiny amount of AIDS funding, which is limited to prevention efforts and does not pay for AIDS care. Greed kills. Access for all.
At that time, I remember hearing about Paul and Jim, who were fighting to treat people in Haiti, where no one had access.
We had a lot of patients in Haiti diagnosed in those years.
Pas de grand accompagnement depuis mon sida, on connaît que la vie est allée, que c'était la mort. Il n'y avait rien à faire.
We start having people coming back from Port-au-Prince. They come back home to die.
A young woman, 28 years old, working as a servant in Port-au-Prince, comes back here to rural Haiti with weight loss, a cough. And then she gets offered HIV testing, and it's positive.
We really couldn't stave off this slow, inevitable, fatal decline without antiretroviral therapy. One of the early patients was Adeline Merson.
Adeline was a young woman who went to Port-au-Prince to try to find a job. Her father had mentioned to us that she was home and very sick. And one day we had gone to see Adeline. She was lying on her bed, and she looked emaciated and somewhat resigned. Her father was standing with her, and he had already been raising money for her coffin. Paul sat there for a long time. He was able to listen to her lungs and her heart. We got up and started the trek back, and Paul said, "There are medicines for this."
Paul started talking to the patients, and they said, "You mean there's a cure for this? If I live an hour and a half away in Miami?" And I mean, it's like, well, how could that not be available to us? I mean, and how do you answer that question?
Meds were available. They were just expensive. Adeline was weeks from dying at this point, and Paul said, "We have to be able to get the meds."
So we made the decision, we have to do this because we're running out of time for her.
You know, at a time when not a single patient was treated using US dollars in a developing country, we all decided we had to try to do everything we could to scrap together a few medicines.
Paul was running around getting, sacks of unexpired drugs that were donated. And then we would triage the patients because we didn't have enough to treat everyone. We treated the sickest people.
Choisir aussi le monde comme un hôtel qui vraiment besoin parce que tu vas bien trop de demandes. Moi-même d'accord avec Ralph, nous va avancer et puis nous allons commencer tout de suite. Parce que l'accompagnateur lui-même qui est important.
And we just used the tuberculosis program that we developed with community health workers and put the AIDS patients in it with the right drugs. And we were supplementing the drugs with food and other kinds of social support, just like the TV program. The accompaniment model. If you want people to survive, do that. They don't have enough to eat.
The results were dramatic and transformative.
Adeline gained 26 pounds in 1 month. And I'd never seen that.
Docteur Paul dit papa non, les mettre jeter planche li yo, lui a besoin faire sécueil pour moi. C'est grâce à eux même qui fait là avec bon Dieu.
Everybody got better.
Et pas gon l'hôpital m'te fait que j'aime dire qui j'en des maladies qui m'te fait. Et bien celle ça a été fait pour moi, il était uniquement préparer tout testament, sécueil moi. Je l'ai m'te venu ici, pas boy ici l'hôpital Cange, et docteur Polo te dit non, on peut pas mourir.
Nobody died in that treatment group. And so the outcomes were just as good or better than in the United States because we had a community health worker system.
Et là, qui ça nous est là depuis ces dates-là? Depuis 2000, moi fait éducation malade et tuberculose avec HIV. Chaque jour, je toujours parler avec eux avant yo et docteur. Qui ça nous a fait là? Yo cherche chez mes cas docteur mais ils vont faire examen tout. Pour yo voir si yo malade avec si yo pas malade.
By 2001, we decided with this handful of patients, about 50, 60 patients, we were going to write a little article saying we treated 60 patients for free in Haiti, and they all gained weight.
There really weren't a lot of AIDS treatment programs, and as far as I know, none of them were in rural areas. We thought it was worthy of underlining, look, if you can do this in rural central Haiti with community-based care, with community health workers, then you can do it anywhere.
It was published in The Lancet, which is big hoity-toity journal. And here I was like so proud. It was the first article I ever was part of writing. I sent it to my parents.
So we had a lot of response to that paper.
The scientific community hated it. They hated it.
The expert opinion was this was too expensive, it's not cost-effective, it's not sustainable.
They said there's no data, it's not sustainable, it's silly, it's gold-plated, this could never be replicated.
It was almost the exact same argument that we're having with MDR. The power of deja vu there was just overwhelming. These drugs cost $12,000 a year per patient. So the notion that you would invest resources in HIV treatment in Haiti or in Africa just seemed like an idea from outer space.
Half of the budget is for antiretrovirals. If we had them today, we could not distribute them. We could not administer the program because we don't have the doctors, we don't have the roads, we don't have the cold chain.
First of all, in their script, we are black, uneducated, of course, stupid. If we give them the drugs, they will not take them on time. You know those black people. They don't have a watch.
If you've traveled to rural Africa, you know this. People do not know what watches and clocks are. They do not use Western means for telling the time. They use the sun. These drugs have to be administered during a certain sequence of time during the day. And when you say, take it at 10 o'clock, people will say, what do you mean by 10 o'clock?
First of all, that's not true about the medication. And in fact, they also did have watches, I might add.
The dollars available are limited. I have to ask you if it isn't more effective to concentrate almost entirely on the prevention part of this thing. Really?
The mindset obstacles, the institutional obstacles, were just enormous.
The lack of infrastructure for the disbursement of the appropriate medicines is so primitive.
These are just excuses. It was all about money.
It's hard to overstate the scale of the AIDS crisis. 12 million people have little or no access to the drugs they need. It costs about £3,000 a year for the drugs each sufferer needs. Globally, that's a bill of £40 billion.
By the year 2000, I was inquiring of colleagues around Harvard what could really be done about AIDS. Paul said, well, we're doing it.
Jeff Sachs said, I'll go to Haiti with you, and he did. He met Adeline in the middle of nowhere in a village where there's no electricity, hours from a road, doing really well.
We saw a woman robust and healthy and going about her daily life.
Jeff looked at our model, made some little marks, and he costed it out on the back of an envelope. And he said, yeah, this is what we think we need to spread this globally.
We were saying, well, we need X number of millions of dollars. He said, forget the M word. You don't need the M word. You need the B word. You need billions of dollars to go in this.
And meanwhile, the AIDS activists were making a ruckus around the world.
We just want an opportunity. An opportunity to live.
I had been invited to debate a guy from the World Bank. The World Bank had not been endorsing AIDS treatment.
You've made a compelling emotional argument, Paul. Yet I'd hope that even those among you who are firmly convinced by Dr. Farmer's forceful presentation will suspend your judgment for the next few minutes to listen to a different view.
He was saying prevention, that's the only thing that works.
I conclude that government should pay more attention to prevention because much of prevention would not be done without government intervention.
And that you don't give a man fish, you teach him how to fish.
It's important to note that it's not just that people haven't been taught to fish. Their boats have been destroyed, their nets shredded, and their fleets have been sunk.
AIDS activists, they had been saying the same thing. You can't say that Africans with AIDS can't get treatment. That's bullshit.
Bankers in generally, my suspicion is they're not getting a lot of sex because they spend a lot of time screwing the poor.
My friends in Africa and other developing countries, die within just a couple of years of being diagnosed with HIV because they have no access to treatment.
We were like, we're going to put pressure on the drug companies. We're going to put pressure on governments, while people like Paul and Jim at Partners in Health were saying, we'll provide proof that drugs can be used in resource-poor developing countries effectively.
None of our patients have died. One person died a few days after starting therapy because we started too late. And isn't that the lesson of the last 20 years? We started too late. We always start too late.
People were saying, wow, you know, if they can do this in Haiti, we can do this in Thailand. If they can do this in Haiti, we can do it in Soweto. If they can do this in Haiti, we can do it in Siem Reap. And people started talking about the Haiti model. And our patients wrote something that is called the Declaration of Conge, and they said, we have benefited from the fruits of science, and we think our brothers and sisters in Africa should too.
C'est Déclaration Conge. Nous-mêmes malades, nous avons mis la santé, dans Conge yo, nous gagnons une déclaration, nous t'avons fait devant nous toutes. C'est nous qui malades, c'est nous qui déclarons souffrance nous, misère nous, douleur nous, espoir nous tout. Nous gagnons un message pour nous-mêmes qui souffrent même maladie avec nous. Nous t'avons dit, pas décourager, parce que vous pas de médicaments. Nous pas jamais bouquer gourmet pour tout le monde capable de joindre médicaments avec bon la soignage. Nous gagnons un message pour gros chabrak yo. Ça qui sorti dans notre pays, ça qui sorti dans le pays d'Haïti. Nous demandons pour nous prendre conscience de tout ça n'a pas duré. C'est pour nous mettre à côté tout égoïsme parce que tout le monde c'est monde. C'est pauvre de pauvre, mais nous pas sortir pour ça.
You know, like any declaration, Alma-Ata, any others, you know, you want to believe it matters. But the difference between the two is pretty shocking, of course, or striking, right? One is a declaration made by, you know, the ministers of health and other political figures, and the other is a meeting of displaying a different kind of expertise, you know?
Nous te dit tout monde c'est monde. Tout monde gen droit à la santé pour yo vivre.
Tout monde c'est monde, ou ka pli riche passé, moi m'ka pi pauvre, mais son seul sang nous gain. Et c'est ça que fait me dire, si bourgeois, milliardaire pas bon l'autre bord, ka joindre traitement, nous même en Haïti, faut que nous ka joindre traitement.
They went back and saw then Secretary General Kofi Annan and said, this really can be done. This can be done at scale, and here's how it can work.
2001, there was a UN special session. Kofi Annan had called for the creation of a fund that would help poor governments treat HIV in their countries. And that then later became called the Global Fund to Fight AIDS, TB, and Malaria.
I propose the creation of a global fund dedicated to the battle against HIV/AIDS and other infectious diseases.
The Global Fund was created with the idea that HIV treatment is possible, and it must be possible because they're doing it in rural Haiti.
If you talk to people now, everyone will tell you that they were for HIV treatment in the late 90s and the early 2000s, but that's just not true. There were a very, very, very small group of people who were in favor of it. The most remarkable person, I have to say, who changed his mind is George W. Bush.
Anthony Fauci, who was head of NIAID, called me and said, you should come to Washington for a meeting in the White House the day after tomorrow. And I said, really? I remember going in, bringing some before and after pictures. I was really nervous. They were saying, how are we going to get these antiretroviral medications to poor people? And I just said,
I know we can do this because we already have in Central Haiti. And you don't need infectious disease doctors like me. What you really need are community health workers. There was a wave of doubters, and I was skeptical that we could convince them.
I'll never forget the day. It was January 28th, 2003. PEPFAR, President's Emergency Plan for AIDS Relief, came out of the blue.
Today, on the continent of Africa, nearly 30 million people have the AIDS virus. I asked the Congress to commit $15 billion over the next 5 years, including nearly $10 billion in new money, to turn the tide against AIDS in the most afflicted nations of Africa and the Caribbean.
I said, holy shit. Actually, I think I had the word F in there. I was blindsided. I couldn't believe it.
I mean, this was really an incredibly gutsy decision to make. And it was done, as far as we can tell, I've never spoken to him about this, it was done on the basis of compassion. When the Global Fund and PEPFAR came online, all of a sudden, we were talking about $10 billion a year for 3 diseases that before was maybe getting a couple $100 million. And so right then, we understood that the fight had changed.
Bonjour. One of our big challenges is how can we help revive the public health system in order to deliver the services we want to deliver.
Once we had the Global Fund and PEPFAR, we said, you know what? The health system in Haiti is falling apart. So we strategically made a big decision that year. Let's use that money to revitalize the public sector, to work with the Haitian government to build health systems, to train doctors and nurses, to put the resources and the structures in place to do it.
This is going to be a new hospital. We will be reclaiming little bits of this, corner by corner, until it looks like Conge. Hish is the TB center starting next month. Tomon, public health clinic. Las Calabas, the future headquarters of this whole expansion. If we're not everywhere in all these places, really seriously a presence, then we're not doing our job and we're way behind schedule. Put Conge on the map.
We knew it could take months for the money to be released, and that time would cost lives.
People are dying every day. For them, we're not washing. What are you waiting for?
We said, let's talk to Tom White. Tom said, I don't have that much left. But he said, let's take a loan from Citizens Bank in Newton. You can use my home as collateral. So this was getting down to the wire for Tom.
We said, we're gonna put essential drugs in the clinics. Not HIV drugs, we're gonna put those too. TB drugs, amoxicillin, family planning. And then we're gonna hire and train and pay a big army of community health workers. So we were pumping our money into the public sector. And then we, if people came in and they were sick, we say, hey, you want an HIV test? Okay. And most people don't have HIV, but they're getting health care.
Our strategy of taking AIDS money and using it to build the healthcare infrastructure in this one small part of central Haiti was attracting attention around the world. The hard lessons we had learned over 20 years were starting to pay off. And then we had a chance to do the same thing for an entire country, to really test the dream that healthcare for all is possible on a much larger scale.
And that's when I met Dr. Agnès Benaguahu. At this big AIDS meeting, it was the first time she ever went to New York. She, walked off the plane with her bag full of articles and commentary. And we hit it off. You can tell she's a leader and isn't very shy.
Well, I was quite impressed because there were all so many knowledgeable people in that room. People who give their view and the world follow their view. But they were quite saying nonsense, And I say, my goodness, if we had to follow that, we'll go nowhere. So as I'm very talkative, I start to talk a lot and to tell them, the real life is not what you say here. Huh? Come in Africa and I will show you.
Rwanda was a country that had been through massive suffering because of outside intervention, including colonialism, World Bank policies, eventually leading to devastating outcomes.
UN officials say they have never seen anything like it.
The true horrors of this month-long war are only now beginning to emerge.
Social services are broken down, the homes are destroyed, victims of the atrocities do not have the medical attention they need.
When the genocide was over, the new leaders resolved to rebuild the country. And it was sometime after that we were invited in.
The government here is organized. There's political will to get things done in healthcare.
What the government of Rwanda saw was an NGO, Partners in Health, that was using HIV money to revitalize primary health care. And that was one of their real big mandates after the genocide, was to rebuild the healthcare system as a way to promote peace and stability.
In 2000, we create an action plan designed with the entire country, and it's Vision 2020. We just say, we need to reach there. Those are our targets. How are we going to do that? It's very ambitious.
We thought with the right support, we could take the model that we developed with our Haitian colleagues and see it brought to some kind of scale.
They say we are experts in rural care and treatment. So we told them, okay, let's give you the worst place in Rwanda. There was nothing in that area. There was a former hospital that has been totally damaged by the genocide.
It looked like it had been raided. And that was the hospital for this community. So we began to bring some of our Haitian colleagues who'd been treating HIV and training community health workers.
Under the tree, under the tent, wherever you could save lives, you start.
Abantu bane bangajwe bwa mbere ku munsi wa mbere Partners in Health.
We started going house to house, and people were so sick.
Docteur Eugène, elle a besoin d'urgence tout de suite. Elle est en train de mourir. Il nous faut de l'oxygène. She's dying. I think it's too late.
Hajo yawe akabahika akabashira no ku mubongo ndetse ni nabyo byaduhaye courage. Turavuga tuti ese ko tubona umuntu w'umunyamahanga ari gufasha abanyarwanda kuki twe tutafasha abagenzi bacu.
The history of the genocide took everything to another level in terms of the emotional intensity.
Ça c'est en fait de la grenade. This child needs the OR. Est-ce qu'il savait que c'était une grenade? Non, il ne savait pas. They were playing like kids.
Aje abantu benshi cyane. Noneho wareba tugerageza kubapima. Abo twapimye wasangaga icya kabiri bose bafite HIV.
The government wanted to place 3 community health workers in every village in the country, 45,000 strong.
Il faut toujours avoir l'engagement dans cette bataille et la conviction. C'est vous, Rwandais, qui devez changer les conditions de vos frères. We were people with the same challenge, people who have to deal with the same social determinants.
This was the first place that I ever saw the country pushing Paul on thinking big.
We give a phone to our community health workers that people can borrow. And we create an SMS platform linked to Twitter so that our people that doesn't have internet can ask any question by SMS.
Luca has an urgent question.
Yes.
He's saying Centre de santé de Kassavo, une rupture de stock, de crachoir.
Le directeur de l'hôpital le plus près, c'est qui? We'll call him right away.
This is stressing me out, Doc.
It's stressing you?
Yeah, it's stressing me in a good way.
Are you still in the hospital? Go by home, passing through a health center, and call us back. You'll do a letter for me on Monday, copy to all the health centers so that this will never happen again. We start to dream and to work together since they have the same vision of what a human is entitled to.
Things like cancer care, surgery, that's what they don't have here.
We are starting a systematic screening for all adults to see what our population is suffering to. We see a new set of disease, many cancer.
We saw many women in their mid to late 30s dying in agony of metastatic cervical cancer. It's the biggest cancer killer of women in Africa. Around the same time, it became a vaccine-preventable illness when the human papillomavirus vaccine was approved. So Rwanda mobilized every community health worker in the country, went out into every school in the country.
They did it. They vaccinated 93% of all 13-year-old girls.
The rest of the world noticed. People wrote articles in The Lancet, in premier global health journals, criticizing Rwanda for giving the cervical cancer vaccine to 12-year-old girls because it could divert attention away from more pressing health problems.
I have a lot of respect and a lot of sympathy for colleagues who object to change, but I have more sympathy for the patients.
These debates are because they are from a poor country. They should not have access to treatment. Make me furious.
Massive costs will prevent many countries from providing treatment at large scale. Countries cannot treat their way out of non-communicable diseases.
I want to emphasize sustainable. Do what you can with what you have where you're at.
There are people who just say, too expensive for you. Who they are to tell us that when we have managed to mobilize? Who are there to say that this is too good for our people?
These low to middle income countries, they need to resist the temptation to want the latest, most expensive technologies.
I am accountable to our people. You are accountable to who? People are dying, my brother. So we commit to treat every cancer possible and to mobilize as crazy to provide them treatment. We want oncologists, we want pathologists, we need them.
Rwanda did something interesting. They said, we're actually going to use our international aid to train the next generation of Rwandan health professionals.
And they said, look, you know, we don't need people coming from DC to give a PowerPoint to tell us how poor we are. What we need is a doctor to train our doctors.
Now I want to invite to the stage Agnes Binagwaho, the Minister of Health of Rwanda.
We negotiate with the US government to divert a portion of the money they give us for health to produce the doctors we need for the future.
All the schools will send 100 faculty members to Rwanda a year, helping Rwanda strengthen its national health education system so that it is sustainable and will be able to be run and funded by the Rwandan government itself.
One of the things that we and our Rwandan colleagues have always been able to do is to make sure that what we're doing is always so ambitious that it makes a lot of people uncomfortable.
A lot of people were scratching their heads and saying, why are you introducing cancer care in Rwanda?
I mean, surely you don't need to do that right now because you haven't yet done this.
You know, that time it was HIV, a couple of years later it was HPV vaccine. Tomorrow it will be cancer treatment. It will be always there. They don't believe that we have an equal right to life. An equal right to dignity. An equal right to say what is our own future.
Good morning, everybody. Despite its name, the World Bank is more than just a bank. It's one of the most powerful tools we have to reduce poverty and raise standards of living in some of the poorest countries on the planet. And that's why the leader of the World Bank should have a deep understanding of both the role that development plays in the world and the importance of creating conditions where assistance is no longer needed. I believe that nobody is more qualified to carry out that mission than Dr. Jim Kim. It's time for a development professional to lead the world's largest development agency. And that's why today, after a careful and thorough search, I'm nominating Dr. Jim Kim to be the next president of the World Bank. So, thank you.
Holy shit.
The next World Bank leader is a leader in world health issues.
President Obama picked somebody who literally everybody who wrote about this today described as a surprise.
This is a big change. He doesn't have an economics background. He doesn't have a finance background. I mean, he certainly doesn't have a political background.
I spent a lot of my time at Partners in Health critiquing the World Bank because it made no sense that there were so many resources in the world and so few were used to stop people from dying from what Paul calls stupid diseases. All of us, even though we were critiquing the World Bank, we all had great hopes that if the World Bank would focus their attention on something, that things would happen. And now in my job at the World Bank Group, it's especially a belief that there's no such thing as a country that is a basket case.
It felt like a long time coming, but it was an amazing outcome to see one of our closest friends influencing on all the issues affecting the poor from the inside. And as it turned out, it was just in time.
We continue to improve. Our people are in better health. But we have more challenges because we don't have in...
I'm sorry, can we hold for 1 second?
Il y a un problème? Oui. Oh là là. Allô, Thierry? Oui? Et il vient d'où? Isolement direct. Tu ne dois pas m'appeler, tu le mets à Kanombe. Vous mettez un lit, vous faites une chambre, tout de suite. Et vous retracez, on s'en fiche. N'envoyez pas le médecin, envoyez l'ambulance, guys. Vous allez juste mettre plus de gens à risque. Vous l'amenez là, il dort là, on fait l'examen, on prend le sang est à Kampala ce soir. Et vous mettez en isolement tous les gens qui ont été en contact avec lui. Tous isolement, bloqués maintenant, tout. Oui, bloquez-les. Thank you. First suspected case of Ebola.
Threats of the deadly Ebola virus finally landing in the East African region. The Rwanda Ministry of Health has come out to assure the public that it was just a suspected case and the test was still ongoing.
All borders are informed and screen anyone coming in Rwanda. And when there is fever, they call us. We have now somebody coming from Congo who have fever. So we are going to isolate another person. If there is any risk, we put that person in isolation. We take the blood and the blood go to an international lab the same. If they are positive, we will quarantine all the people that have been in contact with across the country. Today, we have put 13 people in quarantine for 21 days. We have no choice. That's what we do to assure that the country is safe. A young German coming from an Ebola country, he has fever, sign of Ebola. We had to isolate him to put all the measures against Ebola.
The government of Rwanda was trying to respond as quickly as possible. You know, in order to respond effectively, you have to have a functioning health system.
The community health workers know what to do, and each health center at the border.
So, what is going on with Ebola?
It break my budget.
Yeah, that's what I heard, the isolation. I mean,
No, we have isolation in each hospital of the country. We have checking at 17 borders.
Yeah.
Because this virus is not like the previous one.
Yeah.
Previous one should be over for more than a month.
Yeah, this is the longest outbreak.
Don't be afraid, guys.
Yeah.
The current Ebola outbreak in West Africa is the world's deadliest to date, as health officials in Guinea, Liberia, and Sierra Leone struggle to control the virus.
This is not about Ebola. This is because of a failed healthcare system.
It became clearer and clearer to me that this was getting completely out of hand. The infectious disease doctors I know were more scared than I'd ever seen them before.
I was feeling panicky. It was already wiping out the caregivers, including the professionals.
And I called Paul, and Paul said, "Oh my God, it's so bad. This is the worst thing any of us have ever seen."
I said, you should ring every alarm that you can as president of the World Bank and do what banks do, get us some money.
And then I took a look, and it turned out that nobody had provided any funding for Ebola. That's not what the World Bank normally does, but a crisis like that can affect the global economy.
I want to welcome everyone for this extremely important meeting. Unless we quickly contain and stop the Ebola epidemic, nothing less than the future of not only West Africa, but perhaps even Africa is at stake.
I can't imagine that there would have been another president of the World Bank who could have gotten the bank to invest $500 million into the Ebola epidemic.
The World Bank Group had evolved a lot over years, well before I got there. And with Ebola, we knew we had to act.
This is just crazy. The analysis shows us that it's absolutely idiotic not to invest more in health. Can we do something that makes the case more broadly? I mean, this is important.
We're hoping to build on that case, that through community health workers, I mean, they're critical in reaching out to the underserved, making the connections, and it proved very important in Ebola response, as you know.
By August of 2014, we were invited to both Liberia and Sierra Leone by the governments to have a hand in the fight.
Liberia has lost too many doctors, too many nurses, along with too many citizens because, again, of the lack of staff and stuff.
And that's what's going to build our national capacity to do it ourselves.
It's not rocket science, right? Rebuilding a health system in Liberia or anywhere else, the only impediments in our way are those who are going to argue that we don't need the staff, stuff, space, and systems.
Hello, Ambassador. Good morning. There was a real risk to have brought Ebola in Rwanda. So we did the test on a patient that could be infected by Ebola. And I was called with the result. No, you're welcome, sir. Bye. Vous, les cadres du secteur santé, bonjour. Bonne nouvelle, Ebola négatif. We all know that it's a strong health system that allows to be prepared, that allow you to respond in case of an emergency response.
Rwanda is the most dramatic arc from complete misery and devastation to a recovery.
We dream big without having anything. Now we have universal access to treatment. Life expectancy have doubled.
These declines in mortality are probably the steepest declines in mortality ever recorded anywhere at any time.
I'm going to sleep very well this night. Tell you. We were nowhere. And now the people are looking at us to have advice. How to make it.
Optimism is a moral choice. If you walk into this work and you're cynical and you're pessimistic, well, you know, you probably will live out your very low ambitions.
Early in 2011, we broke ground on a new teaching hospital in Mirebalais, just down the road from where I met Paul all those years ago. We'd always had plans to build a hospital there, but we changed the scope of it after the earthquake 12 months before. It was one of the most unimaginably terrible disasters. In less than 1 minute, so many hundreds of thousands of people died. I don't think that we had imagined anything quite like that. Over the years, we had worked closely with the Ministry of Health in Haiti to build 12 hospitals and clinics that belonged to the country. But after the earthquake, we realized Haiti really needed something we had long dreamed of. A major national teaching hospital owned by the people, through the government, to treat patients, to train Haitian doctors, nurses, and specialists, and make it into something that would actually change things for the future.
Every time I go by that hill where I met Ophelia, I just get a real kick out of going over that bridge and waiting for a modern hospital to loom into view.
J'étais très fier comme un monde qui était là et le tout travail ça a été commencé parce que nous t'ai bâti tout bail ça a sous épaule pas nous.
To come back to that place and to now see this sprawling tertiary hospital, I'm reminded of the road that had to be traveled on to get that hospital there, and how this whole process has been amplified thousands and thousands of times so that we now have many different people working in many different countries.
The key is to have a pessimism of the intellect, but an optimism of the will.
You can't pretend that these problems don't exist, right? Or that they don't have solutions. You know, health for all still needs to be the future.
Tout monde c'est monde. Si moi-même cap vivre jodi, am ta remè pour l'autre malheureux vivre tout.
So much of this work is built on love, and that means going through very difficult times together and sticking with it.
To me, this is about hope. And it's about rejecting despair and cynicism.
Nous remontons au début de quand je nous taillais, pour jusqu'au côté que nous arrivons, journée aujourd'hui, que nous sommes capables d'offrir le monde hospitalité. Avec espoir, parce que espoir en général fait vivre.
Je suppose qu'on a bien fait. Et je me sens heureux si je m'en vais avec le cœur joyeux.
They perdent espoir, moi.
Perdre espoir maintenant. Et puis Kounia.
Espoir tout le Espoir tout le Espoir tout le
When I was In high school, I wrote a paper saying why the right to healthcare was bad. What an idiot.
It's a medical complex in the middle of a squatter settlement. You know, a major medical center in the middle of a squatter settlement. So, of course, a lot of people think that's completely nuts, but the locals think it's great because they think, well, we lost our land, we lost our water, we lost everything. Well, we have a medical center. So, hey, I don't know. It's not what the development experts say to do, but they also have jobs. Tell her what, quickly. She puts a chicken in my hospital. Then it becomes my chicken.
Oh, this is my song. Music. Too long. Beautiful. Beautiful. Okay, so let's go.
We see each other as brother and sister.
Yeah. What does that mean?
You mean that we see each other as family? Yeah, because also that we both each other never had a brother or a sister. So we are kind of related, especially when our fathers are both best friends. They always lived with each other.
Don't make us cry. Don't make us cry.
Oh, so funny.
It's very nice.
It's very
It's
nice.
not funny. It's very moving.
Very nice.
It's
Come
very
here,
nice.
guys.